Hello everyone. In this video, I'll be talking about the ear symptomatology and history taking. That is, what are the common complaints with which the patients present to the ENT OPD, complaints pertaining to the ear, and what are the questions or what are the detailed history with respect to those symptoms that we elicit so that we can narrow down our diagnosis. So, regarding each chief complaint, there is origin, duration, and progress. How did it start? How did it progress up till the present situation, which is also sometimes called as history of presenting illness, that is HOPI. So the complaints in the year, they are always recorded in the chronological order. Chronological order means the first complaint is recorded first and so on. The latest complaint will be recorded last. And these are the common ear complaints with which patients can present in the ENT OPD. They are the most common ones are the discharge, deafness, then vertigo also, pain, which is earache, tinnitus, autophony, facial nerve palsy, sometimes fever and headache. So these are the things with which patients can present in the ENT OPD. So we'll see each complaint one by one. Now ear discharge. So ear discharge is one of a very common complaint with which patients come to ENT OPD. So whenever a patient presents with ear discharge, we should ask the following points. So first is the smell, whether the discharge is foul smelling or non-foul smelling. Now, foul smelling discharge, it is seen in unsafe type of chronic otitis media, that is etequental type of chronic otitis media. And the reason for foul smell discharge in etequental disease is the bone destruction. And that bone destruction is because of the enzymes which are released by the osteoclast. So these enzymes, they are acid phosphatase, collagenases, and some proteolytic enzymes. So they cause foul smelling discharge. Then non-foul smelling is generally seen in safe chronic otitis media or tubotympanic type of chronic otitis media. Now here one point to note is that even sometimes in safe otitis media, because of the superacid bacterial infection, there can be foul smelling. But mostly we see this picture, that is foul smelling in unsafe and non-foul smelling in safe otitis media. Then another point we ask in the discharge is the consistency. Consistency, if it is a stringy consistency, stringy means that when the patient cleans the discharge, then it is the discharge sticks on the earbud and it gets stretched out. So that is called stringy, like a string of pearls. So stringy consistency means that the discharge is mucoid discharge and it is coming from the middle ear, because goblet cells, mucus secreting cells, they are present in the middle ear. So if a discharge is having stringy consistency, then we should always suspect some pathology in the middle ear, and that discharge is mucoid or mucopurulent. Then another type of discharge can be serous discharge. Serous discharge, it means it is coming from external ear. For example, furunculosis. Furunculosis is the staphylococcal infection of the hair follicle in the external ear, which can lead to sometimes serous discharge. And if the discharge is watery, then we can suspect CSF autoria. That is, maybe there is some fracture of the temporal bone and it leads to the CSF leak from the ear, which is called CSF autoria. So consistency is important. Then color of the discharge. So if the discharge is yellowish in color, creamish yellow, we can suspect it is pus. And sometimes because of the Pseudomonas infection, that discharge can be greenish in color. So again, we should ask about the color. Then we should see whether the discharge is blood stained or not. Now, if there is etequental type of chronic otitis media and there are active granulations in the middle ear or the mastoid, then the ear discharge can be blood tinged or blood stained. Secondly, second common cause of blood stained discharge is malignancy. So in these two conditions, the ear discharge can be blood stained. Then we also ask regarding the amount of the ear discharge. Now, amount of the ear discharge, as such, we cannot perfectly measure the amount. But by asking certain questions, we can ascertain the amount. For example, if the patient says that the discharge is so much that it comes out from the ear and it wets the pillow, then we can say that it is profuse discharge. Then, if the discharge doesn't come out from the ear, but it is present in the ear canal when we do the otoscopic examination, then we say it is moderate. Then scanty means the discharge is not present in the canal, but it when the patient or the examiner cleans the ear with a earbud, the bud gets stained. It means this is a very small amount of discharge which is present near the tympanic membrane. Now, the importance of asking the amount of discharge is that scanty discharge, it is mostly seen with etequintal type of CSOM, but tubotympanic type, that is safe type of CSOM, can present with profuse or moderate discharge. So the amount of discharge is also important. Then we ask from the patient whether the discharge is active, inactive, or quiescent. So active means when the patient comes to the OPD, the discharge is present at that time. Inactive means that the discharge has not come for at least 6 weeks. Then we say it is inactive. And quiescent means that discharge was present few days back, but at present it is not there, but it was present few days back. So that is called quiescent disease. Then we should always ask whether the discharge is continuous or intermittent. So a continuous discharge, it is suggestive of etequintal type of chronic otitis media. While in tubotympanic, the discharge is intermittent. That is, it is present whenever there is attack of upper respiratory tract infection, and when that infection subsides, the discharge is gone. So that is intermittent discharge. Then we also ask whether the discharge is relieved by medications or not, because generally the tubotympanic type of discharge, it is relieved by medication, while etequintal, it is continuous, it is not relieved by medication. Then we should always ask the ear whether the patient, if he has previously using ear drops, do they come in the throat or not. The reason is that this gives an idea about the functioning of the eustachian tube. So if the patient instills the ear drops and the patient feels that drops are coming in the throat, it means that the eustachian tube function of the patient is good, and it is a good sign that it is a positive sign for the success of surgery in that patient, tympanoplasty. And then we also ask if there are any associated complaints with the discharge. That is, whether discharge is associated with vertigo, that is any other ear complaint, or discharge is associated with tinnitus or not. So these associations we will see in the along with the next complaints. So these are the things that we ask whenever a patient comes to ENT OPD complaining of discharge from the ear. And of course, we ask whether it is unilateral or bilateral, whether it is coming from one ear or it is coming from both ears. Then duration of the discharge is important, uh, whether it is of acute onset, for example, say few days, so it can be suggestive of any acute pathology, acute otitis media. And if the discharge is coming since long time, say more than 12 weeks, then we say it is chronic condition, for example, chronic otitis media. So the next complaint is now deafness. So this is also one of a very common complaints with which patients come to ENT OPD. Now, if a patient comes with deafness, then we should ask whether it is of sudden onset or it is gradual. So if it is of sudden onset, then we can think of these etiologies, that is viral labyrinthitis or viral infection of the ear, or fracture of the temporal bone. In these conditions, the deafness will be sudden. While if the deafness is of gradual onset, then we can think of chronic otitis media. Then degree of the deafness should be ascertained, mild, moderate, severe. Again, we can do it by doing a series of tuning fork test, that is clinical examination, where we can know that what is the degree of the deafness. Then whether the deafness is fluctuating or not. Now, fluctuating deafness is commonly seen in these two conditions, that is secretory otitis media, because here there is a fluid level in the middle ear. So as the fluid level changes in the ear, the amount of deafness also changes, that is fluctuating. And also in the Meniere's disease, we see that there is fluctuating deafness, because whenever there is an attack of vertigo, the deafness increases, and after the vertigo subsides, the deafness decreases. So in Meniere's disease also we see fluctuating deafness. Then we have to ask the patient that what is the degree of deafness with respect to discharge. Now normally what happens is that whenever the patient is having discharge, it means the patient is having active disease, then the amount of deafness is more. But sometimes what happens is that during discharge, because of ossicular disruption, the hearing improves. because in ossicular disruption, now the discharge acts as a conducting medium for the sound. So hearing improves in those conditions, but otherwise, generally, at the time of discharge, the amount of deafness is more. Next, we ask the patient that whether the patient is hearing better in the crowded places or not. Now, this phenomena, it is called paracusis willisii, and it is seen in autosclerosis, because in crowded places, the persons who talk to the patients with autosclerosis, they will talk in a loud voice. So the patient will say that they hear better in the crowded places. So that is seen in autosclerosis. Then again, in deafness, we ask whether the patient is hearing different sounds of different pitch or not. That is, different sounds, multiple pitch sounds can be heard by a patient, which is called distortion of sound. And this phenomena, it is called diplacusis, and it is seen in Meniere's disease. Then also we ask the patient that what is the relation between deafness and vertigo. So if the during an attack of vertigo there is increased deafness which subsides after an attack of vertigo, then it is a characteristic feature of Meniere's disease. So by asking these questions, we can narrow our diagnosis, that why this patient is having deafness. Then moving further, another complaint with which patients come to ENT OPT, it is vertigo. Now, vertigo, it is a sense of rotation. Now, vertigo, the patient can present in different ways. Okay, so patient can say that either the patient feels he is moving, or the patient can feel that surrounding is moving, or the patient can have a sense of unsteadiness, or the patient will say that there is sensation of to and fro or up and down movement, or he will say that he is falling suddenly. So a proper history is very important to elicit the which type of vertigo is there. And if the vertigo is associated with ear discharge, then it is a grave sign and it indicates that there is some intracranial complications. Then, if the vertigo it is present in a particular head position, then we can suspect benign paroxysmal positional vertigo. If the vertigo is present with deafness, then it can be Meniere's disease. If vertigo is there but there are no other ear symptoms like deafness, then we can think of vestibular neuronitis. It is a viral infection of the vestibular nerve which causes vertigo. And if vertigo is present with the neck movements, then we can think of an cervical spondylosis, and sometimes even osteophytes, they press the vertebral artery and they can cause vertigo with neck movements. So again, we should try to correlate the other ear symptoms along with vertigo, and with proper history we should try to ascertain the type of the vertigo. Now here, uh, this fall off suddenly, that is, patient will walk, suddenly he will fall out, then suddenly he will stand up and walk again without the loss of consciousness. So this is called autolytic crisis, this sudden fall off without the loss of consciousness. This phenomena is called autolytic crisis. Then another important symptom and more common symptom than vertigo, it is pain in the ear or earache. Now, when a patient comes with earache, we should ask what is the nature of the earache. Nature means whether it is of throbbing type. If it is throbbing, then there is pus in the middle ear, that is acute otitis media. And if it is a continuous dull pain, so it can be seen in furunculosis. Then site of the pain is also important, which can pinpoint our diagnosis. If it is in front of the tragus, then it is the common cause is furunculosis. And when we press the tragus in patients with furunculosis, the patient will shout in pain. So that is called tragus pushing test. Then if the patient says that he feels pain deep inside the ear, then it can be a middle ear pathology. If the patient says that the pain is behind the ear, then it can be the inflammation of the mastoid ear cells, that is mastoiditis. And if the patient says that the pain is below the ear, then it can be because of infection of the parotid gland or any pathology in the parotid region. So by asking the site, we can get an idea regarding which part of the ear is affected. Then there is one terminology, referred otalgia or referred pain. So to remember it, we can remember 5 T's. That is tongue, teeth, tonsil, temporomandibular joint, and throat. Now these structures, they share a common nerve supply with the ear. So if there is any pathology in these areas, it will cause pain in the ear, which will be referred pain. So when a patient complains of pain and the ear examination is normal, then we should think of any pathology in these areas to rule out referred otalgia. And if the patient complains of pain during chewing, then it can be seen in furunculosis. With the jaw movements, there is pain. Then next complaint, ear complaint, it is tinnitus. Now tinnitus is the ringing sensation in the ear. So tinnitus can be either subjective tinnitus or it can be objective tinnitus. Subjective tinnitus means that only patient hears the sound. The examiner does not hear the sound. So it can be because of any pathology in the ear or any systemic diseases. So in ear pathology, it can be acoustic neuroma, which is tumor of the eighth nerve, or Meniere's disease, and even some drugs, they cause tinnitus, for example, aspirin and quinine. In some systemic diseases like anemia, hypertension, and diabetes, uh, patient may complain of ringing sensation in the ear. Then some causes of objective tinnitus. Objective means the examiner is also hearing the sound and the patient is also hearing the sound. So some examples are palatal myoclonus, in which there is movement of the palate and it produces sound which is heard by both the examiner and the patient, and sometimes the glomus tumor. So these are the pathologies which are outside the ear. So objective tinnitus is generally present in pathologies which are outside the ear. Then if the tinnitus is unilateral, then we can think of acoustic neuroma. If it is bilateral, then sometimes it is seen in autosclerosis. Then if tinnitus is associated with vertigo, then we should think of Meniere's disease. Similarly, if tinnitus is associated with deafness, then also it is a feature of Meniere's disease. And generally, the in Meniere's disease, the tinnitus precedes the vertigo. So we can say that tinnitus presents as a warning sign that now there will be an attack of vertigo. Then one another common complaint pertaining to ear is autophony. Now, as the name suggests, auto means self, phony means hearing. So here the patient uh, hears excessive loudness of one's own voice. So whenever a patient speaks, he hears his own voice. That is called autophony. Now it can be seen in acute suppurative otitis media and sometimes in non-suppurative like secretory otitis media and patulous eustachian tube. So here the eustachian tube is not functioning properly, and that is why the patient is hearing his own voice. That is called autophony. Then facial nerve palsy. So patients can present with the facial directly with the facial nerve palsy, and if the patient comes with a facial nerve paralysis or palsy and he is having ear discharge, then we should suspect that the patient is having atiquintal type of chronic otitis media, in which the cholesteatoma or the disease has eroded the fallopian canal, and that is the cause of facial nerve palsy. Then if facial nerve palsy is present along with deafness, then we should suspect acoustic neuroma, because acoustic neuroma initially starts with the eighth nerve and then it also uh, involves the seventh nerve. Then if the ear examination is normal, that is there is intact tympanic membrane and there is no discharge, and the patient comes with facial nerve paralysis, then we should suspect Bell's palsy. Now Bell's palsy is the diagnosis of exclusion. So it is idiopathic, unilateral, lower motor neuron facial palsy of sudden onset. That is, if we cannot find any other cause of facial nerve paralysis, then we can diagnose it as a Bell's palsy. Then another symptom can be fever. Now, in the pathologies in the ear which can cause fever, they can be acute infection of the ear, that is acute suppurative otitis media, and acute mastocytitis, and that is inflammation of the mastoid ear cells. So in these two conditions, generally the patient also complains of fever besides the other ear complaints. And finally, sometimes the patient can also complain of headache, which can be because of any pathology in the ear. And if headache is present, then we should always suspect an intracranial complication of chronic otitis media. For example, brain abscess, it can be lateral sinus thrombophlebitis. So headache should be considered as a very serious sign in patients, especially if we are relating it with any ear pathology. It should point towards the intracranial complications of chronic otitis media. So these are the complaints. So whenever patient comes to the ENT OPD with these complaints, we should ask the details of these complaints so that we are able to narrow down our diagnosis. So thank you.